Pension and Health Benefits Committee. We'll call the meeting to order. And then roll call, please.
Ramon Rucava,
Present.
Kevin Palkey,
Good morning.
Deborah Gallegos, Vermilia Cohen.
Here.
David Miller,
Here.
Arena Ortega, Nicole Griffith for Arena Ortega,
Good morning.
Jose Luis Pacheco, Teresa Taylor,
Here.
Yvonne Walker, Melissa Willett.
Thank you. Next order of business, we will now recess into closed session for items 1 through 4 from the closed session agenda. We'll be in closed session for about an hour and a half, more or less, and then we will reconvene into open session after the closed session. Thank you very much.
Sorry, I forgot we play musical chairs during this.
Benefits Committee. We are back in open session and we'll continue with the remainder of the open session agenda. We will continue with the executive report. Kimal and Don Mold, please.
Good morning. Kim Malm, CalPERS team. So welcome to open enrollment. I'm sure you're all aware it started yesterday, and Don will be speaking about it today, but I thought I would mention that the call center received over 8,000 calls yesterday from our members and employers. The average wait time for our callers was 16 and a half minutes. Some callers waited for over half an hour, but the ones with the pro tip of call later in the day, anytime after 4 o'clock, only had to wait about 4 minutes. This is the busiest time of the year for them, and I just want to say thank you to the call center team, including their management, for answering calls and helping our members during this time. I also want to give you a few updates on our customer services, our support services projects. I'll start with the 2025 benefit verification that we started in March, and I briefed you on previously. From this effort, almost 360 deaths were reported across California and 36 other states. I previously reported there were 720 checks held on August 1st, as we had not heard from those members. There are now 564 checks that still have holds in place. In the last month, 9 deaths were reported and 147 payments have been released once we received the certification. So far for the 2025 benefit verification cycle, we found $3.5 million in overpayments, and we've collected $2.6 million of that, 3.5, or 74%. SoCure, our death verification vendor, has reported 598 confirmed deaths since 2024, resulting in $5.9 million in overpayments, and we've collected nearly $4.7 million, or 80% so far. Because of our overpayment initiatives, including benefit verification and the utilization of SoCure, along with other activities, we have recovered almost $151 million in overpayments in the last 2 years. I just want to say thank you to Marcy and to the board for being so supportive of this project. Next, I'd like to share our efforts we began in July to increase CalPERS member self-service registrations. This project aims to increase the number of members registered for a CalPERS account. To date, we've completed a baseline assessment of the CalPERS population, and as of August 15th, 62%, or approximately 1.5 million members, are currently registered with a CalPERS account. The goal is to target and engage the remaining members who have not yet signed up to enhance communication, reduce undeliverable mail, and help prevent fraud. There's a lot more to come on this project, and I will keep you updated as we see the metrics progress. Next, I want to cover recent updates to our member education. We recently aired a monthly member video, Your CalPERS account, for active and inactive members. This aired on August 21st and was later uploaded to our YouTube channel. It received over 1,000 views on that date and earned a 97% positive rating. As of today, the video has now had over 14,000 views. We're also excited to be introducing a new retiree class webinar. The webinar is scheduled for December 9th. Registration will open the week of November 3rd. This post-retirement webinar will cover key topics to help retirees prepare for the year ahead, including first of the year changes, COLA updates, a reminder of health plan changes that will be effective January 1st, and any other hot topics. Next, I'd like to cover our Spanish class offerings. As you may recall, in 2024, we introduced a Spanish language class called Planning Your Retirement Basics, which received positive feedback. Building on that success, as I shared in July, we launched a new Spanish class at our Orange Regional Office, Basics of Your Retirement Application and Beyond. This earned a 100% satisfaction rating with 72 attendees. We're working on system enhancement that will enable us to provide these classes in Spanish on a regular basis. Let me give you a quick update of our CalPERS benefit education events. Our first CB of this fiscal year was on August 13th and 14th, our first virtual, and we had over 2,000 attendees. Our next virtual event will take place on March 4th and 5th in 2026. Our next planned in-person CB is in Monterey on January 9th and 10th. We also have planned CBs in Anaheim for April 10th and 11th of 2026 and June 5th and 6th of 2026. In closing, I'd like to take a moment of personal privilege, Mr. Chair.
Please do.
This is Corrine George's last CalPERS board meeting. Corrine is the division chief of our call center. She has been with CalPERS for 10 years in various areas, such as eligibility and enrollment, Medicare, service credit purchase and elections, branch administrative support, and has been the division chief of our customer experience division, or fondly referred to as our call center, for the last 8 of those 10 years. She has 33 years of public service and membership with CalPERS. Corrine has accomplished many things in her time at CalPERS, including acting as the SLC chair, or Senior Leadership Council chair, an emerging leader program mentor, Our Promise campaign chair, and Idea Factory committee member. Her major projects include implementing the contact center into the cloud, implementing customer service metrics and customer satisfaction surveys in the call center, and currently implementing the call center's first Gen AI summarization tool, not to mention many open enrollment cycles. Corrine is looking forward to having her first grandchild, spending more time with her family, and finally taking the trip she never managed to go on. Please join me in congratulating Corrine on her upcoming freedom. Thank you for the many years of service, Corrine. This concludes my comments, and I'm happy to take any questions.
Any questions from the committee? Yes, we have President Taylor, please.
So, Kim, thank you very much for everything that you do, but I do want to specifically call out Kareem and the call center. We have call centers at my department. I've heard nothing but good about your call centers here, but also the fact that I just heard that you guys took 8,000 calls yesterday. Congratulations, with a very short wait time. So I'm very impressed. You guys did a great job, and I just wanted to give you guys the kudos I've probably never done, but I know you guys have helped 1,000,001 people that are my members as well, so thank you.
Thank you, President Taylor. I'm sure the team is going to love hearing that. Thank you.
Thank you, President Taylor. Trustee Walker.
Hi, Kim, just a quick thing, because I get asked all, Yvonne.
I'm like, who's
Right. And I forget. What is the cycle for the verification?
We do it annually now. So it used to be every 2 years. Now we start in March, and it ends in about the July timeframe, and the checks are stopped in August. So every year we start in the March timeframe. Is that what you meant by timeframe?
No.
Okay.
So don't we do like A to Z is?
So it's based on risk factors, how we come up with who is going to be on that list that year. And so it's determined upon like how much the benefit amount is, if they're out of state is a factor, age, if they've contacted CalPERS in the last year, or if they've been seen by their healthcare provider in the last year.
Okay. Thank you. I get asked that all the time, and I forget.
I'm happy to
So
send
I'd
you
ask
that little
again.
cheat sheet.
Thank you. I'd appreciate that.
Thank you, Ms. Walker. Vice Chair Pocky, please.
Thank you, Mr. Chair. Fabulous numbers. If I don't say it enough, thank you for everything you do, your team, the support that you give to our members. I know that I appreciate it, and I'm pretty sure our members appreciate it too. So again, thank you.
Thank you so much.
Thank you. We'll proceed to the action consent items. Nobody's held anything, and I already have here.
I think, Mr. Chair, I still have.
Oh, I'm
opening
sorry.
remarks. No, it's quite
Done,
all right.
right.
And they're long, so apologies in advance.
I was so excited with Kim Mall's presentation.
It seemed like
Of
we got
course,
away with.
of course.
No, not so fast. So
Please,
I have
Don.
several topics to cover in my remarks today. I'll start with an update on our plans to cover the COVID-19 vaccine that is now ready for fall 2025, as well as recent developments related to vaccine guidance and coverage. Last month, the FDA approved the latest round of COVID vaccines in the U.S., but set new limits on who can get them. The agency ended its broader authorization of the shots, only clearing them for people at high risk of severe illness, That includes those 65 and up and younger adults with at least one underlying condition that puts them at elevated risk. This is a significant departure from previous years when the vaccine was indicated for everyone over 6 months of age and is now inconsistent with the California Department of Public Health's current guidance. It's important to CalPERS to ensure that we continue to provide our members with access to high-quality, evidence-based preventative care. To that end, we have directed our health plans and pharmacy benefit manager partners to continue to provide and cover the latest COVID-19 vaccine for any CalPERS member age 6 months or older who chooses it at no cost to them and without the recent FDA limitations. In reaching this decision, Dr. Logan and I consulted with the California Department of Public Health, our partners at Covered California, and the Department of Healthcare Services, as well as the Governor's Office. Our directive is consistent with CDPH current guidance and guidance from other states. Also, as I know you're aware, California recently announced its intent to join Oregon and Washington to create the West Coast Health Alliance, and now Hawaii has joined as well. The decision was in response to concerns about the lack of transparency and politicalization of the major scientific agencies and groups under the U.S. Department of Health and Human Services, in particular the FDA and the Advisory Committee on Vaccine Practices, or ACIP. Chief aims of the Health Alliance will be to promulgate vaccine guidance and to ensure the public has credible information for confidence in vaccine safety and efficacy. As part of that effort, legislation is now on the governor's desk that would allow California providers, including pharmacists, to administer vaccines based on guidance from leading medical professional organizations, such as the American Academy of Pediatrics and the American College of Obstetrics and Gynecology, and to remove all ACIP recommendation references from state law. We expect that the governor will sign this bill immediately. In the near term, this would allow pharmacists in California to administer the COVID vaccine based on CDPH guidance rather than under the FDA restrictions. We also expect our COVID vaccine guidance will be consistent with the guidance coming from the Western States Alliance when it adopts one in the near future. We will continue to monitor regulatory, judicial, and other developments that could impact members, vaccine coverage, including an ACIP meeting planned for later this week. Dr. Logan continues to be actively engaged with our clinical partners at CDPH, Covered California, and DHCS on the topic as well. So what does this mean for our members? Our members can receive their COVID vaccine at no cost to them, just as they did last year, through their healthcare provider or at an in-network pharmacy. Flu vaccines are also widely available, and members can receive the flu shot at the same time as the COVID-19 vaccine for added convenience and protection this season. We will have more information available in an article we will be publishing later this week, and we will be using our website and social media to inform our members of the decision this week and as developments occur. Next topic. As a follow-up to public comments we received in March from our out-of-state active employees, these are state employees, I'm pleased to share that CalHR and its union reached an agreement to provide state employees headquarters out of state and enrolled in a CalPERS PPO plan an increased monthly payment to help cover healthcare costs. The increased pay differential is significantly higher. It will become effective this December and will reduce the disparity for two-party and family enrollments. So nice news there. The next item to cover is Kaiser's announcement last week that they are expanding into Nevada. As you may have seen reported in the news, Kaiser Permanente and Renown Health have entered an agreement to jointly own and operate a health plan and new outpatient care delivery system that will bring Kaiser Permanente to the northern part of the state. The expansion is pending approval from regulators in the state of Nevada and with CMS on the Medicare side. Kaiser has confirmed that the new service area will become available to members starting at the beginning of 2027. We are excited about the possibilities the Kaiser, Nevada expansion opens up for our members living along the California-Nevada border, particularly in areas like Truckee, Tahoe City, and Susanville, often use our PPO to access care in the Reno area. So we are hopeful that the expansion will open up an HMO option for those members. We also have a large number of members who currently live in Nevada, about 12,000, most of them residing in the north. We've been working with Kaiser to map the new coverage areas and have had preliminary discussions about how the expansion might be folded into our 2027 plan offering. So much more on this topic to come. We've just started the mapping exercise with them, but an exciting and I think positive development for our members. Next, I want to provide a brief update on our transition to Blue Shield and Included Health. Previously, we shared that there were some initial bumps for members, particularly in January and February. These largely surrounded the primary care provider, or PCP, listed on a member's ID card. In some cases, it was not the PCP that members had been seeing in the past, which caused an influx of calls to Included Health in the early months, leading to longer wait times and high member frustration. This was happening at the same time representatives at Included were getting accustomed to working with CalPERS members for the first time and learning firsthand their needs and expectations. Given the high call volume in the first couple of months, the CalPERS team monitored the member experience and accuracy of information provided by Included Health agents. We conducted several rounds of listening sessions, each of which involved listening to hundreds of calls and provided feedback and opportunities for coaching. We conducted call calibration sessions to ensure we were measuring quality and accuracy in the same way. The CalPERS team also reviewed all of Included Health's training materials to ensure their agents share accurate and complete information with members. In the early spring, we conducted a joint in-person Train the Trainer meeting with Blue Shield and Included Health and worked collaboratively to improve the training and reference materials for IH agents and care teams. We conducted another 2-week session of call monitoring in June to assess the impact of the training. We are very pleased to see a pretty dramatic increase in overall accuracy and completeness of the information being shared with our members. This was a priority for us as we head into this year's open enrollment period, and our teams are prepared to answer our members' questions. Operationally, we're also seeing improvements in the handoffs between Included Health and Blue Shield, and we continue to work together on new ways to leverage our unique three-way partnership to better serve our members. We again want to thank our members and employers for their patience and understanding and for the feedback they have shared with us. We continue to use the feedback to further improve and refine the services to our members. Finally, I'd like to remind the committee, as Kim just did, can't do it too much, our stakeholders and members that open enrollment started yesterday and runs for 4 weeks, actually 26 days, through October 10th. This is the annual time members can change their health plans and add or remove dependents. We added even more communications this year to help ensure members are informed of the changes and the resources available to explore the health plan options. With the change to CVS Caremark for pharmacy benefits, we've been working closely with them to ensure a smooth transition and have a lot of information on our website about this change, including frequently asked questions. They are also here with us today as part of our Health Plan Spotlight series, and will cover how they are supporting our members through the transition. This Thursday, we will be hosting a webinar to introduce CVS and provide members with information about what the pharmacy benefits manager change means for them. We've also hosted open enrollment webinars for employers and for members. Recordings of those are available to watch on the CalPERS YouTube channel, and the CalPERS and CVS webinar will be posted there next week. Lastly, I want to highlight that this year we created a Spanish version of our open enrollment newsletter in addition to the English version. Both are available on the website. We want our members to explore their options and to shop health plans during this open enrollment period. We encourage you to take advantage of the tools and resources available and make the best choices for you and your family. That concludes my remarks. I'm happy to answer any questions.
Thank you. That was a lot of information.
A lot,
And our committee appreciates it, and we have questions. So we'll start with Trustee Walker.
Hi, Don. I just want to say, that I don't think people fully appreciate what an outstanding team we have on dealing with the healthcare and everything else. And, because normally we just hear about rates going up and, people, but the dedication that you and your team have, right, is unsurpassed. I really appreciate the fact that as we're going through this vaccine thing, that you guys were on it right away. I had sent you a text message to say, hey, what are we going to do? Like, what happens? You were already on it. I appreciate that. And not only were you on it pursuing a solution for our members, and that you answered all the questions I was going to ask. Are we going to have it on the website? Are we going to? And you were like, so I really do appreciate that. I think that in the coming months and years, at least the next 3, it's going to be challenging for healthcare. We've just had another rural hospital that's going to be closing in Glenn County, which is crazy, to say the least. And so I'll be looking forward in the future of, how we're looking at making sure, at least for the people that we represent, that they stay covered as much as possible. I know it's not easy, but I really do appreciate the dedication with which you guys look to make sure that things happen. So I just wanted to say that.
Thank you for that.
Oh, before I forget, this is just one quick shout out. I want to give a shout out to our colleagues at CalHR. They are having a retiree open enrollment webinar on September 30th. And so, Nicole, I don't know if you want to talk about it more because this is your stuff, but I think that this is amazing and I'm really excited. And for any retirees, it's state retirees, I will say, if you haven't signed up, you should. They have a few retirees signed up, and I think we should have more because this is amazing. So anyway, Nicole, I shouldn't call on you because that's not my job, but I'm very excited about it.
Do you want to say anything? Yep.
Okay, thank you. So yes, we'll have a retiree open enrollment webinar forum. That will be on September 30th from 1 to 3 in the afternoon. We have several retirees registered. We have over 300. So looking forward to having our CalHR administered benefits from our dental, vision, and voluntary benefits come and provide information on the benefits that will be effective for 1/1/26. Thank you.
Thank you, Ms. Griffin. Now we'll proceed with the speaking order. President Taylor, please.
Yes, thank you. And Dawn, I am going to just try not to repeat everything Yvonne said, but I agree with Yvonne. Your team has always looked for ways to bring down costs, to make sure that our members are taken care of, to take steps to make sure that we have always had quality, affordable health care. And I know that I think we talked about this during the briefing, but the fact that you guys are working already on it for the COVID vaccines when we knew it was coming down, and working with our state government, with other states, I think I was at my pharmacy and they already offered me a COVID vaccine. I was like, oh, wow. And I think it was a couple of weeks ago. So I think it was before everything was kind of settled. They were already offering these. So I just want to congratulate you guys for all the hard work you do on that. Everything else, the work you're doing to expand Kaiser, etc. And then congrats to CalHR and to SEIU for the work that we did to make sure that our out-of-state folks were covered better with a more affordable option. So thank you everyone who worked on that. Finally, I just had one question. As we're working with the Western Health Alliance and our own California Department of Health and doing our COVID vaccines and our flu shots and hopefully making sure that the rest of the shots aren't gotten rid of either, do we have any fear that the federal government will retaliate and try to sue us to stop us? Is that a thought? Oh, you're off.
I was on and I shut myself off. Sorry about that. I don't know offhand what the grounds would be. It is always a possibility. These are hard times, and the one thing that we've learned is that the unexpected is sort of expected. So, we and the state entities that have made the decision to go down this route are very comfortable, not just with the science that it is rooted in, but with the legal authority. And obviously, if there is pushback, we will deal with it.
Okay, I appreciate that. So in other words, we can't predict the future, but anything's possible.
But are prepared to address it.
I
if
appreciate
comes.
it. Thank
Yeah.
you.
Thank you, Mr. President Taylor. Trustee Miller, please.
Thank you. And thank you both for these presentations. And again, just so much of it is already said, but how much appreciation I have for the work that the teams have been putting in. And I just want to highlight it just never ceases to amaze me the depth of the complexity, especially of the healthcare negotiations, that entire landscape and marketplace, the dynamics with the providers, the dynamics with the team, the interaction with everything that's going on in the external world, and just the diligence the team brings to this. And it's pretty much a non-stop cycle at this point. It really never stops. I mean, we have open enrollment, but we're already the ongoing planning and negotiations and tracking all the changes in the marketplace. And I think it's easy to just think about it in terms of, it can always be better, and it can. But in relative terms, the progress we've made, the ability to get under the hood more with these negotiations. When I first started really paying attention to this 25, 30-ish years ago, we really, it was a black box. It was so difficult to even have the team preparing for negotiations because it was so opaque. And we really weren't able to utilize our size and our buying power the way we do now. And it's just seeing the evolution of that and how effective the team is, and just hats off. I'm just always impressed. And it doesn't mean there's not more progress we can make, but I see the movement is all in the right direction. And, I just want to share that appreciation with the team. I don't do that as often maybe as I should. So there you go.
Thank you, Trustee Miller. Trustee Jose Luis Pacheco, please.
Thank you, and thank you, Don, for you and for all the work that you and your team do. It's very, very appreciated. I got a question back on the Kaiser Nevada initiative and so forth. What is the timeline in terms of the approval process with the CMS? Do you anticipate?
So I know that it's underway in Nevada and that there are plans, so they may have filed the requisite documents, they may have not, but the idea is that they would be ready to go for open enrollment periods in 26. So fall of 26 is when they have targeted for that part of the process, and then starting in 2027. So we are looking at them specifically as a possible inclusion in the 2027 offerings.
Do you see any challenges with respect to that movement, or is it being fast-tracked right now? Or
I don't know the regulatory process in the state of Nevada, so I can't speak to that. That's always a consideration. So one of the things that we do, or that the Department of Managed Healthcare does in reviewing, is test for things like network adequacy. They make determinations about where a plan can be available based on things like where the hospital is located and ensuring that they have a full network. This is not the first time that Kaiser has expanded. They know how to do this, so I have a high level of confidence in them, certainly. But it could be, I think we will have a sense pretty soon where, as I mentioned, we're doing the zip code matching with them now. We'll have a sense of where potentially they could be available to our members, but there are, as is always the case in these, there will be sort of gray areas that need to be worked through.
Fantastic.
But in terms of level of confidence that this will happen, it's high.
Fantastic. That's great. And then my second question is regarding the Blue Shield Included Health. I know the hiccups that we had in it and so forth in terms of the member frustration with the ID. What are the lessons? Have we learned any lessons from that process?
We learned a lot of lessons, and actually we could have a whole session on the lessons that we learned, and I will say that some of them were built into the transition with CVS. So one of the big ones was that we brought everybody into CalPERS. We did that in the early spring. This year with CVS, we did that in August. So that was a game changer for us. We sat down for 3 days and worked through sort of expectations, communication pathways, and we had people get to know one another both as professionals and as humans, so that when they all went back to their places across the country, because these places now touch all parts of the country, they knew who to pick up the phone and call, and they had a relationship with that person or those people, and that was a game changer. So that is a big one. We really benefited from these listening sessions that we did. So we had a not that small team, but highly trained team here listening for hours and hours and hours through. These are not short calls. To make sure they're all recorded, to make sure that that the quality was appropriate, that the information being given was accurate. That's a very powerful tool for understanding what is going on when our health plans are on the phone with our members. So that is another key learning, that's a powerful tool. We could go on, and I'm not the right person because I was not the person getting into the gory details on this one, but it has helped, I would say, so far with the CVS transition, and will help with future transitions.
I thank you for sharing that. I feel this is actually a really an ideal case study to perhaps to showcase how these things can be brought forth, because I feel that's something we could teach and provide to others, this process. So yeah, and definitely it's good that you're also applying it to the CVS Caremark process, because it's going to be also quite a chore to get that done.
And the team working on both that and working on the Included Health Blue Shield transition, I cannot say enough about them. They worked so hard and so diligently and just kept it up for months and months. This all starts as soon as the contract is signed, and in some cases a little bit before a contract is signed, and it is and so this is work that in the case of Included and Shield started in August and is still continuing. And similarly with CVS, it started in July and is continuing. So, you know, we did not go through a lot of big transitions like this in the past. It is great that we are learning how to do them. They will be better in the future if we need to do them in the future, but it is from the incredibly hard work of the team that has been doing the work.
Fantastic, then. No, thank you so much for that information. I think that's been very helpful. Thank you. That's all my questions.
Thank you. Vice Chair Kevin Pockey, please.
Thank you, Chair. Again, I truly appreciate the work that you all are doing around access for our members. I woke up early this morning just to read an article on hepatitis. And so I'm very thankful that you guys are addressing access, whether it's across state lines, whether it's through pharmaceuticals, but allowing those parents, those individuals to make the decisions that they need to make for their families. I truly appreciate that work. So thank you all.
Thank you. Donna, do you want to cut you off? Anything else? Okay, thank you. It was a very good presentation. Thank you, both you and Kemal. Now we'll proceed to item 3, action consent items. I think Pacheco motion and Vice Kevin Pockey seconds. Okay, I'll call for any discussion on the motion. Seeing none, well, all those in favor say aye. Aye. Any opposed? Any abstentions? Okay, the majority said yes, so the motion passes. Now we go to item 4, informational consent item. Don Moles, back on.
I'm just going to wait a second for our guests to join us. Terrific. Howdy. Mr. Chair, members of the committee, this is the 5th of our Health Plan Spotlight series. Today we are featuring our new Pharmacy Benefits Manager for 2026, CVS Caremark. I have the pleasure to introduce Ed Devarney, Executive Vice President and President of CVS Caremark, as well as Dr. Michelle Gordine, who is Senior Vice President and Chief Medical Officer. They are going to talk about CVS and share more about what we have to look forward to in 2026. So I'll go ahead and turn it over to you.
Can you hear me?
Yes.
So good morning, Mr. Chairman and members of the committee. My name is Ed Devaney. I am honored to serve as the president of CVS Caremark. And on behalf of all our colleagues, I personally just want to take the opportunity to say thank you, not only for the opportunity to speak with you here today, but in choosing us as your partner in delivering high quality and affordable pharmacy benefits. For background, I have spent 27 years in healthcare, 20 years within the pharmacy benefit management industry, all of which has been with Caremark. And one thing I believe that is front and center, not only here within the great state of California, but across the United States, is we have an affordability crisis in healthcare, and that is inclusive of pharmacy benefits. We have coming to market, we have novel and incredible branded therapies that are coming to market. The reality is most Americans cannot afford the price tag of these medications, and it obviously poses significant challenges to payers such as yourself, CalPERS, in managing this. And that's really where partnerships with PBMs, such as CVS Caremark, are really essential, not only in lowering costs, but ensuring that members have access to the medications or the therapies as prescribed by their doctor. I really like to spend some time in talking about what we're doing to create a seamless transition and member experience for CalPERS. We've aligned a tenured and dedicated team to implement to ensure a successful transition. Ongoing, or in addition, we have collaboration with the CalPERS team, and as you guys have stated up front, my team has been highly impressed with the expertise of the CalPERS teams as we have gone through the start of the implementation. We also have ongoing collaboration with the health plans. There's multiple health plans that manage the medical benefits, and it's essential to us that we are on the same page with them, recognizing that members who might have a disruption or a period, that we're working hand in glove with the entire ecosystem to drive the right level of experience for your members. We're also working with your current PBM. It's important for us to bring over or import historical drug level files, open mail order refills, as well as prior authorizations. And said simply, this is all done to reduce the burden on members as they move from one pharmacy benefit manager to another. Onboarding. And I think this is, I'm privileged to be here in the fact that we actually started open enrollment yesterday. And I did want to give you a sense of how that is going, the activity that's happening, and the themes in which we are receiving within the call center. So we got off to a relatively slow start yesterday. By that, I mean we received just over 100 phone calls. We managed those at 100% service levels, and I thought the board would appreciate knowing why members are calling. They're checking on drug costs, and I think this gets back to what I had stated up front. We do have an affordability crisis, and members want line of sight to exactly what they are going to pay out of pocket at point of sale. Plan benefits. It's really more of a confirmation of saying, hey, I know we're moving from one PBM to CVS Caremark. Are there any changes that I need to be aware of? And last but not least is I leverage a community pharmacy today. Will I be able to leverage that community pharmacy tomorrow? Of course, the answer is yes. Digital. We created a microsite as part of this implementation to support open enrollment. And through that, we saw well over 1,000 visits yesterday. And the average duration of the member online spanned just under 7 minutes. And again, going back to the affordability crisis, it was mostly geared toward what community pharmacies are available for me to fill my acute or maintenance medication, or what will my cost be at point of sale as we advance forward. In addition to that, as we think about the onboarding process, we will be sending out prior to the 1/1 date a welcome communication. Within there's going to be multiple areas that the member can focus on. We do provide opportunities for web, caremark.com. We also have an app that is a Caremark Central app, but it's really intended for the member. It's all about to learn about the new plan, the new benefits that they have at their fingertips, locate community pharmacies, again, check drug costs, of which we know is very, very important to not only members here in California, but across the United States, FAQs and more. In addition, we do have a dedicated call service or call center for CalPERS. We have over 120 people dedicated to this relationship, this partnership, and that is available 24/7, 365. These resources are not only available for the members, they're also available for you, the customer. They're available for pharmacies participating within your network, along with clinical support. And last but not least, we realize that members that have more complex regimens require a higher touch or a white glove service. Think of your 3,000 members that leverage the specialty benefit. These members face complex career or chronic conditions, and really a delay with these members in any care can result in clinical consequences, which is why you're seeing us roll out a white glove approach. By that, I mean not only will your 3,000 specialty utilizers receive a mailing, they will also receive one-on-one outreach directly from our experts, and that will be highly focused on the transition and what support they may or may not need. To give you an example of what that might mean, is this high-touch outreach includes welcoming the member, answer any questions they might have, but really aligning on any special needs that the member might have, which might be in-home nursing for infused medications. So in close, I hope I can leave you with, we have a strategic, holistic plan to onboard your members. We enter this relationship, this partnership, with extensive experience in working on large public sector implementations over decades of times. And while we do not anticipate any issues, if they arise, not only will your dedicated and tenured team, but my executive team will also be available, not only to the CalPERS team, but you as a board. And I'll end where I began. I want to thank you for the trust you placed in CVS Caremark as your partner. I strongly believe we are aligned not only on the vision for healthcare, but on incentives placed within the contract. And I look forward to this partnership, what it will yield for your members. With that said, I would like to turn it over to our Chief Medical Officer, Dr. Michelle Gordine, on Population Health Management.
Great. Ed, thank you so much. Thank you very much, Mr. Chairman and members of the committee. As stated, my name is Dr. Michelle Gordine. I serve as Chief Medical Officer of Caremark. I've been in this position for almost 3 years, but I've been in healthcare for more than 30 years, including more than a decade providing public health services at the local and state level in the state of Maryland. A good portion of my career has been involved in population health and value-based care. And that's what really attracted me to join CVS Health, because of the dedicated group of professionals who work diligently every single day to make sure that people across this country receive the medical care that they need and the medications that they need in order to remain healthy. I view the work that we do really is at the intersection of pharmacy and population health. And what that means is that many people are dealing with health challenges, many chronic conditions, for which fortunately we have medication to treat them. But that medicine won't help if you can't access it, you can't afford it, and you don't know how to stick with it. And those are the services that we actually provide at Caremark and that we lead. And so that's why I'm so excited about the work that we are going to be doing in partnership with you. Because based on the contract that we have entered into, we're putting our money where our mouth is. We say that we're committed to improving health. We say that we're committed to providing support to individuals. We say that we're committed to lowering the cost of care, and we're going to prove that in the work that we will do in partnership with you. And that, to me, is very exciting. Because when I think about value-based care and population health, which is where I've spent my career, simply stated, it means making sure that people are getting taken care of, making sure that families and communities are healthy, and making sure that health care is affordable. And that's what we commit to do in partnership with you and your health plans together. We also believe, truthfully, that this could be a national model. I'm not aware of any other contract between a pharmacy benefits management company and a plan sponsor that goes into this level of detail to provide and align incentives. So aligning the financial incentives with the care delivery incentives in order to deliver what we plan to deliver collectively. And so again, that's also very, very exciting. But let me get into a little bit of the detail about how we're going to do this. And this is how we're going to start. First of all, we believe it's important for us to acknowledge the existing programs and services that CalPERS currently offers, the work that you've already been doing, and how we can add value to that. So it's not about coming in and duplicating effort. It's about coming in and listening and learning, as Don talked about earlier in the listening sessions, in order to understand what's already on the ground and where's the foundation upon which we can build and add value. The second most important part of this is really data sharing. Understanding who the members are, who your employees, their families, and the retirees are, and what the specific needs of those individuals are. All of us understand as individuals, as members of families, as people who have at one time or another been patients, that there are different levels of support that people need in order to manage whatever health conditions they're attempting to manage, or frankly, in order to just stay healthy and avoid health conditions. And so our utilization of data is to help us to drill down, and we've actually done this before. So as we've supported other commercial insurers, we have utilized data to be able to drill down take a look at the population of members that are supported by that plan sponsor and identify people who might be on a lot of different medications or have a lot of different health conditions or have challenges in terms of income. They may live in a community that may not have access to care. There may be transportation issues. So we take all of that into account to pinpoint those individuals who are probably at highest risk of not being able to access their medication, not being able to afford their medication, and not being able to stick with their medication. And then we're able to drill down and provide targeted interventions to provide that support. Some people need education. Tell me about what it means. I've been diagnosed with high blood pressure. What does that mean? I don't feel any symptom, so why do I have to take this medicine? Tell me what my diabetes means. Some of it has to do with the medications themselves. Well, how do I take this medicine? Do I have to take it with food? Do I need to put it in a refrigerator? Do I need to take it every single day? What happens if I skip a dose? Those types of things differ from individual to individual, but recognizing the individuals who are at highest risk for not being able to take their medicine and stick with it over the long term is really, really important to our being able to achieve the outcomes that we've committed to in our contract. And so the way that we've done that in the past is by offering a wide range of options because different people prefer different mechanisms of engagement. Some people like face-to-face. They want to see someone. And so utilizing face-to-face resources in order to be able to do that is important. Some people prefer digital, give me an app and let me go onto an app. We actually have a really successful app called Health Optimizer, which provides a lot of the services I just described in digital form. Some people prefer phone calls. So those preferences become important. And again, we've leveraged all of those in the past in order to be able to be successful in what we're trying to achieve here. We provide things like reminders of refills. Hey, your medicine is about to run out. Make sure that you refill that medication so that you don't skip a dose and don't endanger your health. Late to fill nudges. You're late on your refill. Let's give you a nudge to see if there's any additional support we can provide you to refill the medication. And again, I talked about the education that we provide as well. One of the final things I want to highlight before I wrap up is the fact that in terms of data and access to data, which obviously is vitally important because it helps us pinpoint who we can focus on and how we can get that service to them, is that Caremark already has existing relationships with 3 of your health plans, which is great in terms of our ability to be able to hit the ground running. We've identified in the contract 3 specific areas where we're going to focus on improving quality and outcomes: high blood pressure, diabetes, and then high-risk medication avoidance. For the first 2, high blood pressure and diabetes, it's important to note that these conditions commonly occur together among people. And having one of those conditions actually increases your risk of developing another. And so trying to reduce the risk of people having complications, having to go to the hospital is very, very important to us. And so those same mechanisms that I just described to you are what we're going to use in order to be able to assist in achieving the quality and cost outcomes that we've committed to. So finally, what I want to talk about is the third initiative, just for a moment, the high-risk medication avoidance. This is a metric that is not going to go into effect until 2027. But what we're going to do in 2026 is to make sure that we evaluate the data on individuals who are currently at high risk, who are taking multiple medications, and begin to line up resources so that we are able to provide outreach not only to those members, but also to their providers, to let their doctors know, hey, did you know that your patient is on multiple medications? Because as we know, people with multiple conditions have different doctors. And so trying to coordinate that care along with the doctor, going through the electronic medical record to provide notifications to those doctors in a way that we've done very successfully in the past through the access that we have into the electronic medical record, to sort of provide those flags and those alerts to make sure that the care plan for those individual patients at highest risks is optimized to the extent possible. So finally, let me just echo what Ed has said. We are so grateful and want to thank you for trusting us and bringing us into partnership with you. We look forward to working with you to improve healthcare quality, to reduce costs, and to make people's lives better and healthier, not only for themselves, but also for their families and for their communities. So thank you all very much.
Thank you, Dr. Dordine, and thank you, Mr. Devaney. Questions from the committee? Okay, we'll start with Trustee Pacheco.
Thank you. And first of all, thank you for your visit here and your spotlight. I really do appreciate it. I also am very impressed by the partnership between CalPERS and CVS Caremark and the uniqueness of this particular contract. And you spoke very highly, ma'am, regarding the population health management. I'm really impressed of how it could be as a model for the nation, because it's the first time that actually we align both financial, as you mentioned, and clinical incentives together. And I also realize the importance of how it, I think what I've read was that as long as if you don't exceed the projected 6.5% of the cost trend, then the money that you put aside, which I believe is over a 5-year period, $250 million at risk. That's significant, a significant amount of money. And for the first time, this partnership between CalPERS and a pharmaceutical benefit manager has become aligned. I would like to know what's your vision of how this will play out and your thoughts on this, because I just want to get an understanding of it. If you guys could elaborate, either one.
Sure, I'll start, and then I'm sure Ed will add as well. And obviously, I'm going to be looking at this from the clinical perspective, right? So typically in healthcare, what sort of helps to move these types of arrangements forward is to, again, to your point, aligning the financial with the quality goals. So you start out by evaluating what's the baseline. So for the group of members who we are, your members, who we've entered into this arrangement to serve, looking at blood pressure and diabetes, we want to look at what the baseline measures are of their blood pressure. What's their blood pressure right now? How many of those members, what percentage fall outside of the normal range? The same for hemoglobin A1C with diabetes. So again, getting back to the importance of data to be able to evaluate where we are, identify those individuals who are at risk because their blood pressure or diabetes is not controlled. And then that's where the initiatives that I talked about kicked in terms of providing that support that those members need to bring their blood pressure and their diabetes back into control. And in a way, that's really individualized. And we're prepared to be able to drill down to that level to meet the needs of people where they are in order to help them to achieve better quality care in terms of blood pressure and diabetes.
I might just add is, as we've gone through the contracting, as we've gone through the economics, I think it's really important to point out that if you think about over the last 20 years within pharmacy benefit management, it's always been market basket average pricing. And what's really important, where CalPERS stepped up and took a very differentiated approach, is aligning everything to acquisition cost. And I think now you're moving the world of pharmaceuticals away from an opaque environment into a transparent environment. And we think this is ultimately, to your earlier point, this is, in our opinion, this is where the market needs to go, which is part of the reason we're so proud and honored to be partnered with CalPERS.
And I really do appreciate what you mentioned, that we're moving more into the acquisition. You were saying acquisition costs.
Yes.
I think that's something that speaks highly of utilizing the purchasing power of CalPERS is enormous 1.5 million members to align costs and bring those costs in. And again, I'm very much a champion of this. I think this is a wonderful program. I see a lot of positiveness, and I see it as a national model for other systems throughout our nation. So thank you. And those are my questions, sir.
Thank you. Vice Chair Kevin Pocky, please.
Thank you. Thank you for the presentation. I really appreciate the look at the national model. as well. I am not a fan of the BMI calculations. I've got the opportunity throughout the years to work with some extreme athletes and to be on your very best and to have a doctor say you're overweight when you're when your body fat percentages are single digits
Yeah.
is sort of odd to me. But that when you see things like that and you're told that on a regular basis, whether you're an athlete or just an average Joe, it starts to play into mental health issues. And if there's ways that we can find technology that betters those calculations, I think it'll be more helpful to us as patients, so that we're not utilizing medication when it comes to mental health and things like that. Obviously, when I think of mental health, obviously September's Suicide Prevention Month. So anything that we can do to help mitigate those suicide patients, things of that sort. Going back to technology, I know this is a interesting topic with AI and everything. And from day one, we were told that with AI comes cost savings. And I know that it's in its infancy and it's still very young, and we're still trying to figure out where that can be utilized. But hopefully those cost savings start to reflect on the end user, because that's what we see on a regular basis. We don't see it as the company. We see it as our medications going up, right? So any way that we can find those cost savings and bring it back to the members is much appreciated. So,
And I would just answer that is we were a founding partner of what's called the Coalition of Health AI. We have multiple partners, some of which are large employers in the state, including Google. The way we look at it, we do think AI will play an instrumental role in medical and pharmacy benefits moving forward, but the reality is they can only move as fast as the speed of trust. So having the right partners with a Microsoft, with a Google, with us at the table, we do certainly expect some changes, and we certainly expect healthcare to look different in 5 years versus today, but you have to do it the right way. You have to be prudent. I think there are unintended consequences sometimes if you go too fast, which is why we believe we have a leadership position with the right partners to advance it in the right way.
And if I could just add very quickly, in terms of AI and using it responsibly, as Ed said, we are very engaged and involved in all of that. We do not use AI to make clinical decisions at this time. We believe that human intervention and evaluation is important and is required. And so I just want to be very clear about that while we are evaluating the utility of AI in terms of allowing us to be able to do certain tasks relative to decisions that are made with regard to access to medications, et cetera, AI is not utilized in that.
thank you.
Thank you. I want to thank you for the great presentation, but I too, and the committee is, was engaged in the whole selection process, so I congratulate you on that. We look forward to a great partnership. In your presentation, you spoke about the onboarding for CalPERS members, and and Doctor, you spoke about the chronic conditions. So maintenance drugs is a big part that we want to make sure our members continue to get it, whether it's mail order or some other process. So how do you, and I know that one of your slides talked about making sure there's the open private authorization, that there's some continuity. So what are you doing to working with the incumbent PBM to make sure there's a dialogue and people don't get lost in the gap? So January 1, they can continue to get their medication.
Yeah, we're working, we're fortunate within the pharmacy benefit community. With your prior PBM, we do have rule sets of how we engage to ensure we have not only the appropriate data, but also with a laser focus on the member experience. So how do we bring over the open refills? How do we carry over approvals that happen in 25 that we could carry forward in 26, which is Simply put, it's all intended to reduce the friction, but also do it in the right way clinically, so it has the clinical effectiveness on the back end as well.
Thank you very, very much. Thank you for coming to speak to us, and we look forward to the integration of our system, your systems with our medical plans, and hopefully we look forward to a good experience for our members, a healthy experience. So thank you. We do have a caller on the phone on this item. So can we have them?
Yes, Chair Rubalcaba, we have Larry Woodson here from California State Retirees to comment on item 5A. Larry, you are now live and can proceed with your comments.
Yes, can you hear me, Mr. Chair?
Yes, please continue.
Okay, thank you for the opportunity to comment. I would be there in person today, but you'll appreciate that I'm not because I have COVID, and I am doing well. But I do want to, first of all, thank Don and his team for their extraordinary efforts to get the health plans to cover the COVID vaccines. That's great. And the only concern I have is that I've been reading that even when people come into their pharmacies and present that they have underlying health conditions, if they're under 65, some pharmacies are requiring them to come back with a prescription. So, I guess if our members run into that, they'll have to deal with it and maybe let you know. But what I wanted to comment on was the presentation just now on the CVS Caremark PBM. And one thing that was omitted is one of the stakeholders have been concerned about and expressed this concern about the drugs that will not be covered by CVS Caremark that were covered by Optum. And I appreciate the fact that you posted yesterday on your website a list of those drugs. I was shocked to see there were 330 of them. 330 drugs are not going to be covered. Now, I guess, I mean, with my knowledge of prescription drugs, most of them seemed very obscure. I had 2 ointments that are not going to be covered, but it's not, terribly concerning. But that many, and there were some diabetes drugs which were a concern to me. So I just want to bring that up because I think it should have been addressed, and I don't know if anyone can address it now, but that concludes my comments. And again, thank you for the teamwork of the health benefits team. That's all.
Thank you, Larry, for your comments, for calling in. I hope you have a healthy and rapid recovery from your COVID. Thank you for staying for the public comment. You do not have to respond, but I'm sure Don will follow up with Larry. But if you want to make a comment, you're welcome to do so.
One thing I will answer just in response is, as we stated earlier, we're extremely proud to be your partner. We're also extremely proud to be your partner as you have your own formulary you guys create. It's our job as your pharmacy benefit manager to administer it. So I think, in short, this is not necessarily a Caremark decision as much as it is support of the CalPERS decision.
Thank you. And I'm sure Dr. Logan in some other presentations has mentioned how we always try to get a drug that works. It may not be the drug of choice, according to the billboards you see on the freeways, but it is an effective and safe drug. Is that correct, Dr. Logan?
Yeah, if I may just respond to that. All of our, we thought a lot about this in terms of the formulary switch, and we wanted to make absolutely sure that our members had a clinically suitable alternative for every single medication on the Optum formulary and then on the CVS formulary. So that list of 300 or so drugs, each one has a clinically suitable alternative. Many of them, I don't know how many, but many, probably more than 50%, have a generic that's available. So one of the things to help with affordability over the long term is to switch people from the brand to the generic equivalent. And so that was a very thoughtful move on our part and in conjunction with CVS to make sure that our members had a suitable alternative and a generic would be available. If there are any concerns, we can certainly answer them as they come up. We can also, it's important to have conversations with your doctor about these changes. If you have concerns or if the doctor has concerns. If the doctor and you believe that the medication is medically necessary, that brand that's excluded or that drug that's excluded, we do have processes in place, appeal processes, to make sure that members do have that ability. Because that does happen, and we want to make sure we accommodate that as well.
Thank you, Dr. Logan. And thank you, Dr. Gordine and Mr. Executive Vice President, two titles, Executive Vice President, President Deveni. Thank you so much for your presentation. And Larry, I want to thank you because you brought forward some information that I think was needed for members to hear and understand. Thank you very much. Okay, now we'll proceed to 5B, summary of committee direction.
I don't have committee direction, and I think Kim is giving the
No. Okay, no, I don't think so either. So now we'll proceed to public comment. I have a caller on the phone. First I have Cheryl Carter from CSCA Schools. Yes, please.
I'm sorry, I didn't expect to be the first one. My name is Cheryl Carter, and I'm with the California School Employees Association, the other CSEA. And I want to talk about the the CalPERS Pathways to Women's Conference that we attended. And I know some people think that doesn't have anything to do with pension and health, but it did quite a bit have to do with that. When I first saw the title of the conference, I thought, well, what pathways are they talking about? You know, it just says Pathways to Women. But when I got there, I was just, I won't even say overwhelmed. I was excited about all the information that the speakers brought to us. It was amazing. One of the things I learned there was that women didn't have the option to get credit on their own until 1974. Before that, you couldn't buy a house, you couldn't buy a car, you couldn't get a loan unless you had your husband, your brother, any other male relative sign for you. And there was a presenter there who wasn't even 30 and had made her first $1 million. And then we had Marcy get up and give her presentation, and we thought, we have a woman here who's, you know, taking care of our pensions, where not that long ago, women didn't have that kind of voice. And we had someone there who was talking to us about our health benefits. And this presenter said to us that there are over 100 laws on the books that dictate what a woman can do with her body, but there's not one single law on the books that dictate what a man can do with his body. And so she brought to us information about how we can advocate for our own health, how we can fight for what we need to do to take care of ourselves, to do better for ourselves. And with that being said, with all the things and all the changes and all the budget cuts and all the ways that we're trying to save money, this was by far one of the best conferences I have ever attended, and it was well worth every dime and every minute put into it. I appreciate the opportunity to attend. I appreciate everything that you did for us. And last year I was able to invite a couple of students to go. This year I was only able to invite one, but I am definitely going to put that in my budget to include sponsoring other young women to attend. And I hope that you'll do it again next year. So thank you so much.
Thank you for your comments. Next, we have Matt Montgomery, please. And I forgot to say to all the other speakers, but we have 3 minutes allotted for each public commenter.
Good morning, Pension and Health Benefit Committee. We are here today to address concerns we have with Blue Cross Blue Shield, concerns that directly affect the health, well-being, and peace of mind of members like my family. I am here before you as a Blue Cross Blue Shield member, a husband, and a father of 2, whose family care is directly impacted by the decisions made on the behalf of Blue Cross Blue Shield by an outside company. When my family or I need care, we must be able to trust that the prior authorization process is fair and accurate. Yet too often it feels like the company Blue Cross Blue Shield relies on, Evolent, making these critical decisions doesn't fully understand the approved policies and benefits we have paid for, leaving members caught in delays and uncertainty. Do you know what it means for my wife, who is trying to figure out why she is in chronic pain? It means endless phone calls just to find out what's going on. It means waiting weeks, sometimes months, on appeals while her pain continues. It means being denied the very treatments our doctors say are necessary. It means lying awake at night, not just in pain, but in fear, wondering if our insurance will protect us the way it promised, or if it will once again stand in the way of her getting better. For you, these may look like numbers, forms, or codes, but for people like us, they are so much more. They are the mother who can't get out of bed because her treatment is delayed due to constant denials. They are the father missing work because he's on the phone again, begging for answers on why this is happening. They are the child watching a parent suffer, not understanding why help isn't coming. And for us, they are also the question of our daughter's life. Without these benefits, how would her care during cancer treatment have gone if we were forced to wait on prior authorization? The thought of her fighting cancer while trapped in delays is unbearable, but for too many families, that is their reality. We are asking this committee to take meaningful action to hold the insurance companies selected accountable for truly prioritizing the well-being of members they serve so that delays are reduced, denials are fair, and people receive the care they desperately need and are paying for when they need it. Families like mine should never be forced to fight for care we are promised. Sorry, I didn't introduce myself at the beginning. Matt Montgomery. I'm an IT specialist for the California Department of Corrections and Rehabilitations at High Desert State Prison and a member of SEIU Local 1000. Thank you.
Thank you for your very strong comments. They were heard. We have a caller on the phone.
Yes, Chair Rubalcaba, we have Michelle Bichal here to speak to item 5C. Michelle, you are now live and can make your comments.
Hello, can you hear me? Okay. She mentioned my name, Michelle Beauchamp. I'm a officially retired teacher. I'm actually semi-retired. I still work February through May, doing testing in my district. I received and read the letters explaining the cost increases, and I saw in the closed session on the agenda was preliminary and potential health benefits program proposals for 2027. So looking forward to that. When you discuss this in your closed sessions, I would propose that you consider capping further increases, or at least trying to keep them at a minimum, not placing any further burden on overall on subscribers, but specifically PPO supplemental plans, retirees that have incurred increases not just with the premiums, but with Medicare as well. The Platinum and Gold received the highest, 13.8%, which is included in the letter. And C, take a more equitable approach to the increases, especially for retirees on limited income, given that there was a tiered approach. And I'll get to that point a little bit later. Currently, for example, for the Platinum plan at $665 a month, it's above the average national range of between $450 and $650 for comparable plans. So we're going at a pace that's not sustainable, in my opinion. And on the long-term view, I see this perhaps out of the scope of the committee's control and many control, that this is all part of the healthcare transition I see over time. It's long and painful. We call it change, but I think it's a long, painful process of trying to move towards a universal healthcare system versus a private system, according to the European model. And that's why you have younger people saying, I'm tired of living here. I'm going to go somewhere else. The grass always looks greener. But I just see it in that context. And specifically, in terms of numbers, I'm sure you're aware of this, but I did a little research in history, and looking back about 4 or 5 years, I'm looking at 9.9%, 22 to 23, 6.6%, 24, 30% with the big transition to Blue Shield, 30.4%, and now this year 13.8%. And the big question mark is 2027. So I hope you consider that. For me personally, that's a big chunk with the increase in Medicare. The trending on that is, 165, 175, 185, 206, 2027, big question mark. So the escalation is not singular, and this is nothing new to everybody in our concerns about access and quality care and financial management of it. But between premium for Platinum, Medicare, dental and vision, which I opt for, which at my age kind of necessary, and then some medications for diagnosis I received a few years ago where the medication might be available, but uncovered by insurance is 2 years ago was $250 a month. Now I shopped out in Canada for it, out of pocket, still not covered by insurance. It's another $100. So I'm looking at about $1,000 a month in healthcare expenses. And my choice to get the premium. So I did look at a comparison plan last year. I stayed with it, thinking I'm going to write out the change. And now I'm not so sure I can do that, but I'm on the back nine, as they say in some arenas, in the mid 70s. So I'm maintaining good health, and that's a positive. I'm pretty proactive, but there's the reality of the 80 marker when things do come up, and expect the unexpected, as was mentioned. So I prepared for that, but I guess my population dynamics kind of do play a part in these decisions, and it just leaves retirees at 65 plus in the position of perhaps being aged out of the healthcare system.
You've gone over the 3 minutes. Can you please summarize your comments?
My questions for you are: 1, can you foresee a cap on increases? Can you see a more equitable application of the percentage increases across the plans? And 3, in light of the trends that I pointed out, what is the best case scenario? Would it be a reasonable stabilizing percentage increase on premiums? So I just ask that you consider that in your discussions about 2027, because the past is the past. We are where we are, and I'm a solutions person for the front. So
Thank you, Michelle.
hopefully you'll take
Appreciate
those.
you. Appreciate you
Thank
calling
you.
in. Michelle, thank you for calling in. We appreciate your comments. With that
Thank
public, thank you. With that public comment, we adjourn this meeting. And next meeting will be the Finance and Administration Committee. In how many? In 15 minutes. Thank you. We're adjourned.
Finance and Administration Committee just shortly here. So I'd like to bring the Finance and Administration Committee to order. Can we start with the roll call?
Kevin Palk,
Good morning still.
Melissa Willette, Frank Ruffino for Fiona Ma,
Present.
Lisa Middleton,
Present.
David Miller,
Here.
Jose Luis Pacheco,
Present.
Ramon Rubacaba.
Present.
And for the record, I'd like to acknowledge Reina Ortega is with us, as well as, Teresa left. So just very quickly, I want to take a point of order. I want to thank Lisa Middleton for joining us back on Finance Committee. Thank you. Michelle, next, the floor is yours.
Thank you, and welcome, Ms. Middleton. We're glad to have you back. I know this is your favorite committee. Okay, good morning, Ms. Chair Palkey and committee members. Michelle Nix, CalPERS team member. First, I would like to highlight the agenda item 4D, where you will find the 457 plan recognition from the National Association of Government Defined Contribution Administrators, or NAGDA, by being honored with the 2025 NAGDA Leadership Award for Excellence in Plan Innovation and Participant Outcomes. The plan has enhanced accessibility by introducing online enrollment capabilities. We will receive this award later this month at the NAGDA Annual Conference. This same agenda item provides information regarding the SEPT program, which as of 6/30/25 has assets under management of $312.5 million, and this is an increase of 19% since last year. We've added 8 new employers for the SEPT, and thanks to our ongoing education and outreach efforts through our webinars, meetings with employers. During the month of July 2025, CalPERS Financial Office offered all contracting public agencies the opportunity to make a lump sum prepayment of the required monthly unfunded accrued liability to receive 3.4% discount on their annual payment. During the month of July, 79% of the employers made the prepaid lump sum payments totaling $4.6 billion. This represented 72% of our expected UAL payments for the fiscal year 2025-26. I also wanted to let you know that we are on track to deliver the annual comprehensive financial report to you in November. Your external audit firm, BDO USA, is currently working on auditing and verifying the financial statements and their report, as well as the ACFR, which will be presented to you in November. The agenda before you today consists of the Treasury Analysis and Liquidity Status Report, Pre-Funding Programs Annual Status Report, and Pension Contracts Management Program Annual Report. Additionally, the agenda has 2 action items seeking your direction. The funding risk mitigation event that was triggered as a result of actual investment performance exceeding the threshold of 2% above the discount rate for the 2025 fiscal year, and the proposed regulation changes, Articles 7.6 participation in risk pools that clarify CalPERS operational procedures for maintaining risk pools and to refine criteria for rate plans to enter and cease participation in the pool. We also have 2 information items, annual actuarial evaluation for the terminated agency pool, and the first reading of the PERF actuarial assumptions associated with the asset liability management cycle. The next Finance Administration Committee is scheduled for November 18th, 2025, and will include semi-annual contracting prospective report, contracts administration, affirmation of the investment manager's contracts that do not have a defined duration, annual discount of accounts receivable, pension contracts management report, annual contract and procurement activity report, the 2025-26 mid-year budget revisions, the 2024-25 basic financial statements, the asset liability management report, the second reading for the PERF actuarial assumptions, and lastly, the semi-annual health plan financial report. Thank you, Mr. Chair. This concludes my report, and I'd be happy to take questions if you have them.
So if anybody has any questions, if there's none, I will congratulate you on your award. This, I believe, is a true testament to the staff and the teams that we put together here at CalPERS. And so again, congratulations on that acknowledgement.
Thank you, Art. The team here is with us today, and they'll be happy to hear that. Thank you.
With that, we move into action consent items. What is the pleasure of the committee? I have a motion to approve by Mr. Pacheco. Do I have a second?
Second.
I have a second by Mr. Ruffino. All those in favor say aye.
Aye.
Any abstentions? Any nays? Ayes have it. Thank you. Information consent items. I do have a request to pull 4D. And, yep, thank you. Mr. Rubalcaba.
Thank you for allowing me to speak to that item. I too wanted to congratulate the team for the NAGDA award. So I think it's been covered, so we can move forward with the adoption. Thank you.
So that moves us into Agenda 5A. Ms. Nix.
All right, let's get started with the funding risk mitigation event. There we go. Thank you. All right, Michelle Nix, CalPERS team member. This item is being brought to you today because of a funding risk mitigation event that has occurred with the investment return at June 30th, 2025, with an investment return of 11.6%. So it's a good thing. Slide 2, please. The purpose of the policy is to reduce CalPERS funding risk over time and thereby increase the long-term sustainability of the CalPERS pension benefits for our members. The funding risk mitigation policy was changed in April 2024 to require an action item to be brought to the board when the investment rate of return exceeds the discount rate by 2% or more. Next slide, please. This slide's just a reminder that the risk mitigation funding policy sets forth thresholds in years where CalPERS has earnings above the discount rate, which currently is 6.8%. This year, we exceeded that discount rate by 4.8%. The action before you today is to decide whether the discount rate and expected rate of return should be reduced by 0.05%. Next slide, please. This slide shows an actuarial illustration of how a decision to reduce the discount rate would impact employer contributions. Over time, there's a decline in contributions projected for the miscellaneous plan, but lowering the discount rate would slightly lower this decline in contributions. So we are getting, the 11.6 would lower the contributions, but not as much with this change. And another way to say that is, over time, contributions would slightly increase from the original projections that make up the reduction in the assumption. Next slide, please. This slide shows the possible impact of PEPRA members and their rates with a reduction in discount rate and assumed investment rate of return. The staff is recommending that we make no changes to the discount rate and expected investment rate of return since the formal asset liability management or ALM process is currently underway during this time. I would also like to remind the board that there are several mechanisms that are currently in place to allow you to lower the discount rate. The first of that is the board can just decide to lower it at any time. The second is that the ALM process exists for the mid-year and every 4 years, the formal process whereby you get to discuss and lower the discount rate if you so choose to do. And lastly, this funding risk mitigation policy discussion that happens when we exceed our investment rate of return and discount rate. And the last slide. All right, so this is an action item for your discussion and consideration. That concludes my presentation, but I'd be happy to take any questions if you have them.
There we go. Mr. Rubalcaba.
No, I understand the policy point is to basically bring stability to the investment return. So given the staff recommendation, I would move that we adopt the staff recommendation and maintain the current discount rate.
So I have a motion by Mr. Rubalcaba, and I have a second by Mr. Pacheco. Is there any other discussion? Ms. Middleton.
All right. I'm going to keep this short. I'm looking forward to voting for this, and the stability that we are providing for our employer community by this maintenance is something that I know finance officers all across the state of California and city council members and county supervisors are going to deeply appreciate. Thank you.
Thank you. Seeing no other requests to speak, let's take a vote. All those in favor say aye.
Aye.
All those opposed? Any abstentions? Hearing none, it's approved. 5B, Ms. Nix.
All right, now we start the actuarial portion, the actuarial show. So I'm going to bring up Scott and company, and we're going to wow you with the actuarial terms. Go ahead, Scott.
Good morning. Thank you. All right. So today we're talking about the risk pools, and the pools that we're talking about is the pools for the ongoing contracting agencies. We're not talking about the schools pool, terminated agency pool, or anything else. We're talking about the pools that were established for the benefit of small contracting agencies a couple decades ago. So unlike school employers, who all provide members with the same benefits and all have the same employer contribution rate, public agencies that contract with CalPERS have historically had contribution rates that were specific not only to the benefits that employer provides, but also to the experience of their own members. Next slide. So that last part, that was problematic for the smallest agencies because individual demographic events for a plan with very few members, like sometimes even a single retirement or a single disability, could result in a relatively large change in the employer contribution rate. So CalPERS eliminated this problem in 2004 when risk pooling for contracting agencies was implemented and mandated for small agencies. For over 20 years, pooling has successfully provided the smallest contracting agencies with contribution rates that are as smooth as the largest agencies. Over that time, the actuarial office has, from time to time, made minor changes in the mechanics of pooling. The most recent change to pooling of any significance was in 2014 following the enactment of PEPRA, which I'll elaborate on that in a little bit. Next slide. So why are we changing pooling regulations now? So if you look at the red line of the pooling regulations, it looks like there's a lot of changes being made. Really, these changes fall into three categories. We have some updates in wording. These are procedural changes that have already been made and the terminology has changed, but they're not changes in actuarial methodology. There's some clarifications. Some legislative changes have made some of the regulations obsolete or outdated, so we can simply remove them. And we want to allow the largest agencies that are in the pool to leave the pool. Right now, once an agency enters the pool, there's no provision that allows CalPERS to remove it from the pool and create a non-pool plan regardless of how large that agency becomes. Next slide. So originally, a little history lesson here, originally there was a different risk pool for each active benefit formula. So we're talking 2% of 50, 2% of 55, they all had their own pools, as well as pools for inactive plans. Gains and losses are calculated in the aggregate for the whole pool and spread across just the employers in that pool. And gains and losses, well, we'll go on about that. So some of the risk pools at this time were quite small. The smallest risk pool had fewer than 600 active members because the benefit formula wasn't that popular. This is the main reason why there was no provision originally to allow pool plans to transition back to non-pooled should they grow, because we wanted to make sure each pool remained large enough to be viable. So when PEPR was enacted, new benefit formulas came in, but not only that, the classic benefit formulas were basically closed to new members. So there would have been 12 risk pools at that time, with all of the classic ones beginning to shrink over time. And at that time, we actually already had a very small benefit formula that was combined. So we did know how to combine different benefit formulas into a single pool. So we had been doing that. So rather than deal with this one pool after another collapsing, we came up with a different solution, which was to collapse them all. In 2014, the pool structure was collapsed into just two pools. There's one for all miscellaneous members and one for all safety members. And they're quite large. The safety pool has 16,000 active members right now, approximately, and miscellaneous pool is about 38,000. So there's no longer this concern that a pool could shrink too small if a few agencies were removed from it. Next slide. So a couple of the kind of technical changes. One of the procedural changes had to do with something we call side funds, and this is written right into the regulation. This was a mechanism that was used to account for the plan's funded status at the time it entered the pool, but we no longer use this terminology. We still do something similar, but we haven't established a side fund since about 2014. And so the reference to side funds doesn't need to be in the regulation. It's as simple as that. Next slide. There are some clarifications in terminology that we need, especially if we're going to talk about which plans go into the pool, which plans go out of the pool. Like, what is a plan? When we remove a plan from a pool, which group or groups of members are going to transition from a pooled plan to a non-pooled plan? The regulations need to be written in a way that it's unambiguous. Next slide. Okay, so now we're going to talk about the rules for entering and leaving the pool. This is the rule that we have now. If the number of active members in a non-pooled plan falls below 100 on evaluation date, we're talking about June 30 of each year, they're mandated to go into the pool. And we also have a rule where, well, if they're over 100 and they want to go into the pool, the employer can elect that. This is not something that happens very often, but we do allow it. And those are the only rules. There's no way right now to leave the pool. Next slide. So the new rule, we basically have 4 zones, if you want to think about it. So the first one on the left is, again, if the non-pool plan falls below 100 active members, they're mandated to go into the pool. This is the same rule we have now. If they have between 100 and 149 active members, the employer can elect to go into the pool. So for plans in this range, 100 to 149, there's really no change from what we have now. Between 150 to 199 active members, we're proposing that plans in this range, if they're in the pool, they can elect to go out of the pool and become a non-pool plan. And then the last one on the right is if they're 200 or more, and this is the real change that would impact employers, is if they're 200 or more on June 30, we would take them out of the pool. Next slide. So what would what does this mean? How many employers are we talking about? So right now, CalPERS has about 1,500 contracting agencies. This would impact the miscellaneous plans for about 14 agencies. There's no safety plans that have grown this large. It's just these 14 miscellaneous plans right now. And this would not be implemented until, at the earliest, the 2026 valuation date. So we're not talking about the valuations we just published or the ones that we're working on and we'll publish next summer. We're talking about the June 30, 2026 valuation, which sets the rates for the 28-29 fiscal year. So this chart, the way we laid out this histogram, is to illustrate that these 14 plans are somewhat outliers. We have that first group of plans that are under 100, which is over 1,400. And really, if you want to split it up further, most pooled plans have less than 25 active members. Okay, so they're by and large much smaller than these 200. And we do know, well, some are over 100, right? Because we move them in when they're under 100, they can grow. We don't move them out. We know there's going to be some above 100. That's intentional, but even after 20 years, 98% of the plans are still below 125, if you look at those first two bars. So these ones that are 200 and over, it sounds like a lot, 14 plans, but it took 20 years for this to evolve to where they were under 100 to grow over 200. We don't envision this happening very often once these 14 are removed. And next slide. This is another chart that is to illustrate where they fit in terms of non-pooled plans. So the last chart was pooled plans. This is non-pooled plans. These are all over 100, of course. These are the distribution of non-pooled plans. And you can see that the 14 that were, the orange ones are the pooled ones that would become non-pooled. And you can see that they're not particularly small non-pooled plans, right? They're larger than a lot of them. And it's worth noting that in our experience over the last 20 years that these plans with over 100 that are non-pooled are working just fine. We've not witnessed any demographic events that made us look at the results and see, wow, this plan would be better off if they were pooled, right? They seem to operate just fine as non-pooled plans. And you can also see that there's about 130 of them that are below 200, right? So there's a big block between 100 and 200. All the ones that we're moving out of the pool are over 200. There's quite a few of them that are smaller than them. Next slide. And this is just to show that the question is like, why did we pick 200 as a number? And part of it is what I said is we're confident that they will be fine as non-pool plans. But for administrative reasons, we don't want plans going in and out of the pool. That's another reason why we didn't want any coming out of the pool before. Now, we do move plans out of the pool, right? We do move them into the pool when they fall below 100, and we do move them out of the pool if they terminate their contract with CalPERS. So we do know how to move them in and out, but it's not something that we want to happen frequently. We don't want to move them back and forth. So what this is designed to show that, well, how long if we moved somebody into the pool, say we have a brand new agency, they have 95 members, we're going to put them in the pool, how long can we expect them to stay there? And based on our experience, well, most of the ones that went from less than 100 to over 200, it took over a decade. We do have a few there that did it in as little as 5 years. So that is why we didn't want to set the 200 really any lower, because it could mean they move in, only stay there for a few years and move back out. And it's administratively burdensome, not just for the actuarial office, for the financial office, and for the employers. So that is why we chose 200. And with that, that concludes my prepared remarks, and I'd be happy to take questions.
So I have one question. And just really, are you seeing any potential impacts to an agency when the plan is removed from the risk pools?
Yes. So we did look closely at these 14, well, not these 14, but the 14 that would be removed, well, which includes the 12 that you see there. We did contact them. We did analyze them and contact them to discuss with them what the impacts would be. There's two main things that are measured differently in the pool versus out of the pool. That's the normal cost calculation, which in the pool, we calculate the normal cost on the entire membership of the pool. And as a non-pool plan, it's just on the members in the non-pool plan, so the normal cost can be different. And the other is gains and losses. Again, well, the whole reason for the pool is that gains and losses are spread across the pool, whereas a non-pool plan, they're not. The biggest risk, of course, that employers face is the gains and losses from investment gains and losses. Now that is not different in the pool versus out of the pool. It's other demographic changes, and those are very difficult to predict how they might be different out of the pool. But we do know that a non-pool plan is only going to pay for the gains and losses that their own membership experiences, which could be viewed as a benefit on its own to the non-pool plan.
Thank you. So we have a motion on the floor. I'm going to have Ms. Willett.
Thank you. Thank you for the presentation. Really enjoyed it. I move to approve the staff recommendation to amend sections 588, 588.1, 588.2, 588.3, 588.4, 588.6, 588.7, and 588.8, and repeal sections 588.5, 588.9, and 588.10 of Article 7.6 of Subchapter 1 of Chapter 2 of Division 1 of Title 2 of the California Code of Regulations to clarify the CalPERS operational procedures for maintaining risk pools and to refine criteria for rate plans, to enter and cease participation in a risk pool, followed by submission of the final rulemaking package to the Office of Administrative Law upon conclusion of the 45-day public comment period if no public comments are received.
I'm going to share my appreciation for recordings on this motion. Is there a second? I have a second from Mr. Miller. Thank you. So I have a first and a second. Any other discussion? Seeing none, what is the pleasure? All those in favor say aye. Aye. All those opposed? Any abstentions? The ayes have it. Thank you, Ms. Nix. Moving on to 6A, information items.
Okay, for 6A, we're going to turn it over to Julian Robinson.
Yes, good morning, good afternoon. I'm Julian Robinson, Actuarial Office. Happy to present the results of the June 30, 2024 valuation for the terminated agency pool, the TAP. And before I begin, I'd like to thank all of the actuarial analysts on the team who put in a lot of hard work and long hours in getting the numbers together, and appreciate their efforts and all the efforts of the actual analysts in the office. Can we go to slide 5, please? As of June 30, 2024, the terminated agency pool, the TAP, is well funded with a funded status of 230.5%. The assets approximately 370 million, liabilities of approximately 160 million. As of June 30, 2023, a year earlier, the TAP was also well funded with a funded status of 209.7%. So the question is, why did the funded ratio change? So if we go back to slide 4, the funded ratio increased since the prior valuation. This is due mostly to an increase in the assets and a decrease in the liabilities of the TAP. So on slide 4, the reason why the liabilities decreased is because the discount rate changed. In the 2024 valuation, we used a discount rate of 4.34%. In the prior valuation, we used a discount rate of 3.75%. So when discount rates rise, liabilities fall. If you look at slide 6, it's a tongue twister, The increase in the non-immunized portion of the assets significantly increased, and that was because the non-immunized segment of the assets is invested in with the rest of the PERF, and there was a nice investment return in the 23-24 years, so that led to an increase in the value of the non-immunized portion of the assets. So putting all those pieces together, that's the reason why the funded ratio moved from 210% approximately to 230%. The discount rate that we use in the valuation changes from year to year. And the reason is that the rate that we use is the 30-year U.S. Treasury separate trading of registered interest and principal securities, generally known as strips, to determine what the discount rate is. And the reason why we use a much lower discount rate is because once plans enter the pool, CalPERS has no way of reaching out to the employers for additional contributions. Unlike current participants in the CalPERS system, where we do annual valuations and we determine contributions on a year-to-year basis, and we can vary those contributions to fund the plan. Once plans go into the terminated agency pool, they become an obligation of CalPERS. And the position that the system has taken is that the assets of the TAP are invested very conservatively in basically treasuries or TIPS, or inflation-protected treasury bonds. So we have part of the assets, the immunized part of the assets, which cover the expected cash flows, and then any additional piece, the non-immunized part of the portfolio, is invested with the rest of the PERF. I don't really have any further comments at the moment, so I will open the floor to any questions which you may have.
I am not seeing any questions, which speaks to the point that we have really great teams, because I think when you guys lay out this information for us with so much detail, it's hard to ask any questions that haven't already been answered just in the material itself. So if there's no other questions, thank you.
Thank you, and look forward to coming back next year. Thank you.
6B.
All right, we have a team for 6B. This is the actuarial assumptions portion of our ALM process. So you heard our recommendations in the investment committee yesterday, but we would like to give you some more detail on exactly how that came about and additional assumption changes that we might recommend. So I'm going to turn it over to the actuarial team.
I guess it's still morning, so good morning, Mr. Chair, members of the committee. I'm Fritzi Archuleta, member of the CalPERS actuarial team. I'm also joined today by Mr. David Clement. We are here to present item 6B, which is an information item regarding the 2025 PERF actuarial assumptions, also known as the 2025 experience study. We realize that you might be actuarialed out at this point, so we will keep our presentation short but informative. Next slide. Okay, so today we'll start with what the experience study is and why we do it. Then we'll walk through some of the key assumptions that shape this study's recommendations. We'll also take a look at the cost impacts to the plans if the recommended assumptions are adopted, and what impacts these recommendations have on PEPRA member contribution rates. Finally, we'll wrap up with next steps. Next slide. So as a refresher to the April board presentation, here's an overview of what an experience study is. So in order to assign costs to the system, the actuaries must make assumptions about the future. Using these assumptions, we calculate our best estimate of what the expected costs will be for the future. It is important to note that these assumptions only determine the expected costs for the future. As time goes on, expected costs will likely differ from real-life experience, and contribution rates will need to be adjusted. These assumptions play an important role in shaping the funded status, required employer and member contributions, and financial reporting information. The assumptions are also used to determine actuarial equivalent factors when a member retires or purchases service credit. In an effort to keep pension contribution rates as stable as possible, we don't want to understate or overstate any assumption, as it is better to collect contributions as service is earned. So if you'll bear with me for a second, I'd like to just tell you a story. Whenever I talk about actuarial assumptions, it reminds me of the time that Mr. Clement and I went to go play basketball. So, it was a really exciting day, fun. I get out to the court and I take my first shot and I miss a little bit to the left. Dave laughs, but then he takes his shot and he misses a little to the right. And we look at each other and we high five. So there's a moral to this story. There's actually two morals to this story. The first one is, with assumptions, you can miss to the left a little. That's okay, as long as the next year you miss a little to the right. I mean, it's as if you sank the bucket, right? Okay. Second moral of the story is actuaries should never play basketball. Okay, so back to the presentation. This experience study is not only important to solidify funding for the system, but it's also required in the public retirement law. At CalPERS, we review our assumptions every 4 years, and the last study of this kind was done 4 years ago in 2021. Next slide, please. So what assumptions do we review? There are two types of assumptions, economic and non-economic. On the economic side, we review the long-term investment return, discount rate, and inflation. For the non-economic side, we look at expected pay increases, mortality, and expected rates of retirement, disability, and termination. All of these assumptions are important, but because the discount rate is so impactful on the costs, it has its own study, which you heard about yesterday at the investment committee meeting. Next slide. Now that the study is complete, here are some of the key findings. Pandemic experience was largely excluded from the assumption setting due to anomalous results. By and large, for the most part, assumptions, there were no significant changes. Inflation was the biggest driver of costs. Higher long-term inflation also has implications on future salary scale increases. Implementing a higher inflation rate will increase costs for plans. Finally, as you heard yesterday, the team is not recommending any changes to the 6.8% discount rate. We'll now do a deeper dive into some of the important assumptions. Next slide. Next slide. Thank you. So yesterday you heard that we are recommending no change to the 6.8% discount rate. Our office believes that this is the correct number given the proposed reference portfolio and risk limits. Even though the next formal study won't happen for another 4 years, we will do a mid-cycle review in 2 years, and our office continues to keep a close eye on the expectations and experience along the way. This is to ensure that this assumption continues to be appropriate. I will now pass the mic to Mr. Clement to go over a few more key assumptions.
Next slide, please. There we go. Good afternoon, Dave Clement, actuarial office team member. Let's look at inflation first. This was the biggest driver of costs during the experience study. Next slide, please. This graph shows the history of inflation, specifically CPI-U measured since 2009. The blue line shows the year-over-year inflation. The orange line shows the 20-year rolling average, and the black line shows our inflation assumption. As you can see, since 2021, the inflation has been above our assumption, and so consistently above our assumption. Next slide, please. The Cleveland Federal Model is a tool developed by the Federal Reserve to forecast inflation trends in the U.S. This is another tool that we look at when we do inflation. The gray, light blue, and dark blue jagged lines in the chart are the expected 10, 20, and 30-year inflation assumptions. The black line is the CalPERS assumed inflation. Once again, you can see the expectation is now exceeding our assumption consistently since 2022. Next slide, please. Another tool that we look at is the difference between inflation-linked and non-inflation-linked bonds. This graph shows the yield between inflation-linked and non-inflation-linked bonds for 10, 20, and 30 years compared to the CalPERS inflation. As you can see again, the inflation is exceeding our assumption. Next slide, please. Some observations. Not shown in the previous slides is the Social Security trustees' intermediate assumption, which is 2.4%. The Cleveland Fed range would imply a rate between 2.2 and 2.6%. The bond market spread would suggest a range between 2.2 and 2.6. We recommend increasing the inflation assumption from 2.3 to 2.5%. Next slide, please. Now let's look at salary scale. Salary scales depict the percentage increase in pay a member would receive over their career. Entry age and service dictate what that percentage is expected to be. Because salary scales are directly tied to the inflation assumption, salary scale was the second biggest cost driver in the experience study. Next slide, please. This table shows the average merit increase by plan type over the last 14 years. The bottom gray row shows the average increase over that time period. For example, CHP had an average of 3.46% over the last 14 years, while overall the average merit increase was 2.7%. Next slide, please. Some observations. For salary scale, we are recommending changes to all 10 sets. The results across these sets are mixed, meaning some groups received higher merit increases than expected, while others received lower increases. The groups which experienced the highest historical merit increases than expected were state miscellaneous, state safety, and state peace officers and firefighters. In addition, public agency fire had higher increases than expected. Next slide, please. Other results. For public agency miscellaneous, police, CHP, and other safety, we saw moderate increases, while two groups, state industrial and schools, had moderate decreases. Next slide. Mortality. Mortality always seems to be a topic of interest when we do these studies. Mortality rates dictate the probability of death at any given age. Because mortality is improving over time, the actuarial office creates mortality tables based on each individual birth year, also known as generational mortality. That is to say that someone born in 2025 would be expected to live longer than somebody born in 1971, say. Next slide. This chart displays actual experience versus expected experience in female mortality over the last 8 years. The dotted line is strictly based on the number of actual deaths versus the number of expected deaths. This is a good starting point for our analysis, but you can see that at almost every point the dotted line is well above 100%. Still, since all lives do not receive the same benefit, we made adjustments to our mortality to not only account for the number of deaths, but also to take into account the benefit amount a member receives. Our study consistently proves that people with higher incomes generally live longer. With benefit amounts taken into account, the solid line below the dotted line is now the actual to expected. You can see these numbers are much closer to 100% on average. You can also see from the chart that the actual expected ratio is higher than 100% in the pandemic years of 2021 and 2020, but revert back to 100% in 2022. Next slide. This chart is similar to the previous chart, except it's for males. Next slide, please. Some observations. Overall, we decided to exclude pandemic data as it did not provide any value towards shaping future trends. Prior to COVID and in the years following, the CalPERS mortality rates aligned well with prior actual experience. Mortality is set by two factors, a base table and a table forecasting improvement for the future. Our recommendation for this assumption is to keep our base table the same as the table used in the previous study, except for some minor changes to the female base rates, and to update the improvement scale based on the newest table published by the Society of Actuaries. Next slide, please. This chart compares the life expectancy of a 55-year-old. The current study are in the solid bars versus the prior study in the dotted bars. Females are expected to live 1/10 of a year longer, while males are unchanged. Next slide, please. This chart here is similar to the last slide, but now displaying the life expectancy of a 1-year-old. As with the previous chart, females are expected to live 1/10 of a year longer, while males are unchanged. Now I'll pass it over to Fritzy for overall cost impacts. But before I pass it over, obviously that story earlier was fictional because I would be swishing it and she would be breaking it.
It's not true. Thank you, Dave. Next slide, please. So before we go over the overall cost impacts, I just want to point out that all of these numbers were calculated based on no change to the discount rate. Okay, next slide. So this chart shows the cost impact of every major assumption change recommended in this study. The column to the far right sums these changes to show the total impact to the employer rate. This chart pertains to state miscellaneous, state industrial, and the schools plan. You see a lot of arrows in this chart. I just want to explain them a little bit. The little arrows numerically mean that the impact of that assumption was less than 0.5%. The number is underneath the arrow, but and then a bigger arrow means that the impact was greater than 0.5%. So as was mentioned previously, the two biggest cost drivers were larger than expected salary increases and larger than expected inflation. Although salary did not impact state industrial and states and the schools plan as much as it did the state miscellaneous plan. Next slide. So similar to the previous chart, this chart shows the impact to the employer contribution rates for state safety plans. Next slide. So for public agencies, there is a range of impacts based on the benefit formula the plan offers. So let's just take a look at that top row. If you're a plan that offers 2% at 60 to your members, you would likely see an increase in your rate anywhere between 0.1% to 0.9%. Okay? Now, the median change is also displayed there for reference. And so just as a reminder, the median refers to the middle data point set where, half the data points fall below, half fall above. So again, for the 2 at 60 miscellaneous formula, half of the plans will see an increase above 0.3%, and the other half will see an increase below 0.3%. Sorry. The bottom two rows of this table correspond to the PEPRA formulas. Anytime we make changes to the actuarial assumptions, the changes could trigger a change to the PEPRA member contribution rate. And so we'll discuss that in a few slides. Next slide, please. So before we move on to PEPRA impacts, here's a chart disclosing the impacts to the funded ratio of the system. As a reminder, the funded ratio is simply the ratio of plan assets to plan costs. So as of June 30th, 2024, our most recent valuation date, we estimated the funded ratio of the system to be 74.4%. If we were to implement that assumption change or the proposed assumptions, that would lower the funded ratio by 0.3% to 74.1. This is depicted in the two columns right above the 6/30/2024 mark. So recall the recent July press release where the funded ratio was reported to be 79% because of that 11.6% return. If we were to incorporate the recommended assumptions, the funded ratio would drop slightly to 78.6%. And that is depicted by the two columns over the 6/30/2025 date. Okay, so next slide. Next slide. So this chart shows the estimated changes in total normal costs for all PEPRA groups belonging to the state and schools pool. The bottom two rows of the table show the range of possible changes to the total normal costs for both miscellaneous and safety public agencies. Recall that a change of 1% to the base total normal cost rate would trigger a change to the PEPRA employee contribution rate. From the table, you can see that the recommended assumptions will likely trigger a PEPRA employee rate change for some public agency plans, as well as the peace officer and firefighter state plan. The formatting on the last line is a little confusing to read, so I just want to clarify that the range of normal cost changes to public agency safety plans is anywhere from negative 1.8% to positive 1.5%. Okay, so next slide, please. This slide quantifies how many plans we anticipate will see a PEPRA employee rate change and how many actives will be impacted. Let's take a look at the not affected row. This means that there are roughly 1,400 miscellaneous plans corresponding to about 155,000 active members, and 227 safety plans corresponding to about 10,000 actives that will likely not see an increase to the employee contribution rate. Good news. But the next row down, there are about 9 miscellaneous plans, 1,700 actives, and 551 safety plans, roughly 16,000 actives, that will likely see an increase to their PEPRA employee rates. So there are some actives that will be affected. And finally, there are even 4 plans that will see a PEPRA employee rate decrease, which is good. All right, so let's go ahead and go to next steps. So this, next slide, thanks. This presentation is the first reading and it's an information item. We will bring this item back to you in November for a second reading, and we will ask you to adopt the recommended assumptions as an action item. A coordinated effort is taking place behind the scenes to make sure that my CalPERS, along with internal spreadsheets and external calculators, are updated, so that if this item is approved in November, there will be no disruptions to member services. Next slide. So that concludes the prepared remarks for our presentation, and we're going to open it up to questions.
Thank you so much for that presentation, and thank you for the basketball analogy. I have Jose Luis Pacheco.
Thank you. Thank you, Chair Palki. And thank you for your presentation. I want to go back to the question on the, let me just get it right now. I'm getting, yes, on the inflation and the price inflation adjustment. You went from 2.3% to 5%, and you utilized several of the Cleveland Federal Reserve model, as well as the I believe the bond model, as well, bond market model. And I'm just wondering, did you give any particular weight to either one of those models in your determination for the 2.5%?
These are all just metrics that we use. One of the things that we didn't point out in the presentation, we also looked at like what the other systems and across the state, across the country are doing as well. And so I don't know that we necessarily assign a weight to either of those measures, but they're just kind of things that we use to guide us in what we believe is the right direction.
So you used other systems.
We also looked at other systems and what they're assuming at this point, and it's a range. Definitely 2.5 is in there. Some are higher, some are lower.
Some are higher, some are lower because of the. But given the current economic inflationary status right now, and taking that into account, that's where we landed on the 2.5.
Yeah, absolutely, that's correct. We believe the 2.3 is too low.
Okay, very good then. And then the second question is on the mortality. You're making the assumption that we would use 80% of the mortality table. I'm just wondering if that's. Can you explain the rationale behind that?
All right, I'll take that one. So when we're saying we're using 80%, it's the tables we're talking about is an improvement factor. So it means how quickly is mortality rates decreasing? How much. When we say an improvement factor, that means people are living longer. So the rates of mortality are decreasing. So how quickly are those rates decreasing over the years? And the Society of Actuaries publishes a table based on, they collect a lot of information and data from various retirement systems. CalPERS does participate in that. And they create what we call an improvement table. What we do is we look at that improvement table and we compare it to what we've experienced for our population, and we make a judgment on how does our rates of improvement compare to those tables. The reason we're using 80% is you can think about, I think we have a healthier population to begin with. So we have less room to improve going forward than a more general population that has worse mortality to begin with. So when you think about it, we're in a better spot. We have better mortality. But how likely is it that everyone's going to live well beyond 120, 130, 140 years? You're going to hit a point where the mortality kind of converges and everyone has the same mortality at those upper ages. And that's kind of what we're seeing with us using an 80% improvement factor versus the 100%.
I see. And then, like for instance, in the beginning, when we had the COVID impact, that we had a spike in mortality.
Yeah. We did, and pretty much everyone across the country did, and even the Society of Actuaries, when they developed the tables, they excluded the COVID years as well because they were seeing spikes in their information that they received, and they felt just like we did that it was a short-term occurrence, and we didn't want to use that in our projections for long-term.
Excellent, and that's why we excluded it from our analysis.
That's correct.
Okay, excellent. Then those are my questions. Thank you, sir.
Thank you, Mr. Ruffino.
Thank you, Mr. Chair. And before I ask the question, I want to come back and, on behalf of the Treasurer, Fiona Mott, congratulations to your entire team, Ms. Nix, on your remarkable achievement, on the award. Obviously, your dedication, your teamwork, commitment to excellence has paid off, making everyone proud. So, well done.
Thank you. It was all the team, though, not me.
With respect to question, the first one, I wanted to ask about the demographic assumptions. So retirement behavior shifted, obviously, during COVID, right? Do we have reason to believe that those changes are permanent, such as early retirements, for example, or delayed retirements? And how have those patterns been reflected in the assumptions?
I can take that one. So yes, we did actually see a spike in retirements during those pandemic years, but we also had the luxury of seeing the next 2 years after that. And what we did see for most of those retirement termination, things like that, those all kind of returned to normal. And so, because of that reason, we largely just excluded pandemic data. And so to answer your question, how did that affect what we ended up setting in the end? It really didn't. We just kind of ignored those years and moved on. And so, by and large, there were not too many significant changes to the retirement patterns.
Okay, got it. On governance and oversight, what metrics or perhaps signals will staff track over the next 4 years to determine if these updated assumptions remain valid or need earlier adjustments?
So every year we just incorporate a new set of, extra 4 years of data, and we probably drop off the years in the older years. But when we take a look at that, we look and see, did we miss to the left 4 times in a row? If we did, we probably need to make an adjustment. But did we miss to the left, to the right, to the left, and the right? Then we don't need to make an adjustment. And so that's kind of what we're looking at. Like, are we constantly seeing losses because we have too many retirements? Then we probably need to up the probability that people are going to retire. So those are the kinds of things that we're looking at when we do our study every 4 years. Does that make sense?
Sure.
Okay.
Yep. Okay, great. Thank you. Thank you, Mr. Chair.
Thank you. I probably shouldn't ask this question, but I am. But knowing how wonderful our teams are, I know you guys are already on top of it. But as far as communications, is there anything in the works?
Sure. We are actually already working with public affairs. This is actually, the second time around that we're pretty good about communicating. And so we have a whole comms plan. There's going to be a couple circular letters. We update our website to ensure that, employers that are affected by this will have form letters to inform their employees if there's, a member rate change. And of course, we'll model these changes in Pension Outlook as well. If the changes are actually adopted, employers will have the ability to do a radial button toggle and see what the impact is due to theirs, for their specific plan due to these assumptions. And then obviously at the Ed Forum, we'll do a big, presentation about these assumptions.
So, sorry, before I get to Mr. Rubalcava's question, the toggle button, is that part of the My CalPERS account, or how does that work?
Yeah, so in Pension Outlook, there's a bunch of modeling assumptions. And usually what we do is, we'll ask a yes/no question, model the new assumptions. If the user puts yes, then it'll revise the projection for their contribution rate and funded ratio with, incorporating the new assumptions in there. So they'll see if their costs go up or down due to that.
Great. Yeah. Thank you. Mr. Rubalcava.
Thank you. Great work. One thing, actuarial assumptions always, you want to make sure the experience matches your assumptions. And as we can tell from the colleagues, mortality is of much interest, and that is a key demographic assumption that impacts the rates. But the economic ones are the ones that actually make the bigger impact, and one of them is inflation. That increased. And traditionally, the expected rate of return includes an inflation factor. So our recommendation is to not change the rate of return and the discount rate, which are similar right now. How do we adjust that given that we're changing? I'm not saying it's not justified, but how do we calculate that given that the inflation rate did increase?
Can you I'm trying to understand your question. How do we?
Yeah, because isn't inflation is always a component when you calculate the rate of return.
Yeah, so when
we're changing one but not the other.
Yeah, so when
I just want to make sure we're within the
we're
actuarial standards of practice.
Yeah, so we're within the standards of practice. So when we looked at the CMAs yesterday, if you remember, we had a list of the CMAs for the various asset classes. And when we developed the reference portfolio and the active risk, inherent with those returns that were displayed yesterday is an inflation assumption. And the surveys that came back, there were, I think, 21 responses, and the inflation assumptions varies between those responses. But when we look at the returns, it takes into account the inflation. It's not like the net return that we're looking at. We're looking at the nominal rate of return. So when we were looking at the 6.88 for the 75-25 portfolio, that's a nominal return. And underlying that is an inflation assumption. Based on the work we've done, our recommendation was a 2.5% inflation assumption, and we had conversations with the investment office in terms of where they felt the inflation was. They had a very tight range, and our numbers were consistent with theirs in terms of 2.5 was an appropriate assumption for their numbers and for ours as well. So we kind of came out from two different sides, but we made sure there were consistency between them.
Maybe I'll follow up later. I was not suggesting it was not a reasonable assumption. I'm just trying to figure out. Usually they move. Usually there's a movement in both. And I didn't see that. Maybe I'm wrong.
They don't always move together.
Okay,
I mean, they've convenience. Basically, what you're saying is the real rate of return stays constant, and it fluctuates when you change inflation. In this case, inflation is going up and has been elevated for the last 4 years and projected to remain higher. With the returns just not being there, there was kind of no justification. Something has to give in terms of that equation. inflation's higher and the returns weren't going up. We didn't see inflation's jumping
So
up
that's
above.
the answer, that the real rate of return is sort of
Decreasing,
went down.
yes. Yes.
Okay, thank you. Appreciate it. Good work. Thank you. And thank you for explaining the, what they call it, the weighted generation mortality, where depending on your income, you may tend to live longer, and that's something that's has been studied at least recently. It's very interesting. Thank you for mentioning that. Thank you.
Not seeing any other questions. Thank you for the presentation.
Thank you.
6C, summary of committee direction. Ms. Nix.
Thank you, Chair Palkey. I took no committee direction for this particular agenda.
Nor did I.
All right, great.
Thank you so much. That leads us into 6D, public comment. I have one request to speak, Mr. J.J. Jelensik.
J.J. Jelensik speaking for myself. Doesn't relate directly to this committee, but I would urge you to immediately go into the perf and comp open session, which is probably going to last about 10 minutes before you go to lunch. That way, those of us can listen to Doug's comments and then disappear for the day. So I would encourage the board to take that action. Thank you.
Thank you for your comments. That concludes our open session, and we do not have a closed session today. So we will reconvene with PCTM. When would you like?
Just a reminder to the board, the ice cream social starts at 1 o'clock, where we're serving ice cream to the team.
So we'll start up with PCTM just after 2:30. Yeah. So see you all at the social. Thank you.
That's fine. 3:10.
Good afternoon. We will call the Performance Compensation and Talent Management Committee meeting to order. Can I please get a roll call vote? Roll call.
Melissa Willette.
Here.
Malia Cohen. Michael DeToy.
Here.
Arena Ortega.
Here.
Kevin Pauke.
Good afternoon.
Teresa Taylor.
Here.
Yvonne Walker.
Thank you so much. Also acknowledging we have other board members in the room, Frank Rufino from Fiona Ma, Jose Luis Pacheco, David Miller, and Ramon Rubalcava. We'll take the first item on our agenda, our executive report.
Thank you, and good afternoon, members of the committee. Michelle Tucker, CalPERS team member, standing in for Doug Hoffner. Today we have a very brief open session for you with standard consent items prepared for the committee. Then the committee will move into closed session for the annual CEO performance evaluation. At the committee's next regularly scheduled meeting in February 2026, the committee will receive the CEO's mid-year status report. I'd also like to provide a quick update on the status of the board's primary executive and investment compensation consultant request for proposal. Our team is currently reviewing the proposals received and tentatively scheduling finalist interviews for late October or early November. The current contract with Global Governance Advisors expires in January of 2026. Thank you, Ms. Chair. That concludes my report, and I'm happy to answer any questions.
Thank you. Are any questions from the committee or board? All right, we have none. Excellent. We have our action consent items, of which we have two. The approval of the September 16th, 2025 Performance Compensation and Talent Management Committee timed agenda, and the approval of the June 18th, 2025 Performance Compensation and Talent Management Committee meeting minutes. I got a motion to move to approve from Kevin Pauke, and I had gotten a second from Teresa Taylor. All those in favor?
Aye.
Any against? And any abstentions? Okay, that motion does pass. Thank you, committee. With that, we'll move, the information consent items are on your agenda. We have no requests to pull any of those. So, summary of committee direction.
Thank you, Ms. Chair. I did not record any committee direction.
Thank you, and I will now move to public comment, if there is any. Nope. We have no request for public comment at this time, so we will now move into closed session. Thank you so much. We are now in open session of the Performance Compensation and Talent Management Committee, and we will adjourn the meeting.